Bueno, seguimos con la presentación de Kazak. Yo ayer la presenté, así que, y ella en su video, en la presentación de hoy, también hace referencia a sus lugares de trabajo. Vuelvo a decir que le agradecemos infinitamente la generosidad con que ha compartido ayer y va a volver a compartir hoy todo su trabajo de investigación, y todos esperamos poder aplicarlo a futuro, ¿no? Después de estas charlas, seguir en contacto. Y los dejo con el video para tener tiempo para las preguntas.
Hello, my name is Ann Kazak. It's a great pleasure to have the opportunity to talk with you and to do this presentation as part of your meeting. We have a lot of shared interests in children with cancer and providing treatments to them. I truly wish that I could be there in person with you to talk and to get to know you, but this is the best that we can do for right now. I hope that you'll find this presentation helpful. I look forward to talking with you and having the opportunity to interact at the end, live and in person. So my goals in this presentation are to provide a little bit of background on the development of the psychosocial standards of care for children with cancer and their families, to present, actually go through each of the 15 standards to give you a sense of their breadth and scope, to talk about a study that we conducted looking at the readiness, the preparation, the current state, if you will, of centers in terms of their ability to implement the standards. And throughout, I hope to help you link what we've done here with the standards to your own work. And I've had the opportunity to review your website and some of your materials, and I'm so impressed with all of the work that you're doing and see so many ways in which your work is very much congruent with what the standards represent. I wanted to say just a little bit about where I work. I work at a large children's health system in the United States called Nemours, and we are based in both what is known as the Mid-Atlantic area, Delaware, Pennsylvania, and New Jersey, and also in the Southeast in Florida and Alabama. So the research center that I direct cuts across those centers, and across all of those states, we have the good fortune to be able to see quite a large number of children. I would like to also introduce the Brown family and the Mattie Miracle Cancer Foundation. Matthew Brown was a little boy who had osteosarcoma. He died in 2009 at age 7. And his parents, Vicki Brown and Peter Brown, created a foundation, Mattie Miracle Cancer Foundation, which is dedicated to providing psychosocial care and improving the status of psychosocial care to children and families. They are our close partners in all of this work, and honestly, we could not have accomplished the standards without their passion and the commitment of their foundation. I'd like to give a little bit of perspective on how long it takes to accomplish standards. We began our first major step in developing standards, dates back to 2012, when, with the support of the Mattie Miracle Cancer Foundation, a group of us went to talk to our lawmakers, our legislators on Capitol Hill, the United States Congress. And we were fortunate enough to have a number of attendees from across the country, to have representatives from both major parties in the United States come together in their shared interest in this topic. And we had an opportunity to talk to them and to say, look, this is very important work, and it's not included in any laws and policies of the country, but we think it should be. We think this is very important. And the meeting went very well. And at the end of the day, the question that the Congress people asked us basically was, well, show us the evidence, pull this together so that we have documents and we have, concise summaries of all of the work backing up what you've talked about. So that's what we did, and that's how we got to the standards. So we started by saying, well, what do we know? We have a substantial body of research from over 35 years that really shows the evidence of the impact of cancer on children and families. And I'm sure you're well aware of this work as well. We also have a lot of people over time who've called for translating these findings into evidence-based interventions. Say, okay, let's help people. Let's do more with this. But although there is much knowledge and there are many calls for action, we also know that the services that are provided to children with cancer and their families can be very inconsistent, and inconsistent even within the same hospital. So this is a problem, and continues to be a problem when we look at providing care in a systematic way so that everybody is receiving the needed care. As we moved to generate the standards, we first reviewed all of the guidelines, recommendations, and standards that were already out there. We also began to ask psychosocial experts, what are the most important things that we should know about families to provide optimal care? We began to generate ideas about the challenges to implementing psychosocial care. And we wanted to be creative and think about how could we do this in ways that would get around some of the barriers and take advantage of the many things that we have to offer. As we developed the evidence, if you will, as we begin to pull things together, we wanted this to be strongly evidence-based. So in our systematic reviews, we graded the evidence using a system actually called GRADE, to be able to say what is the quality of the evidence and the strength of the recommendations that we're going to make. And you'll see as we go on that there was a little bit of variability in the strength, but we really wanted to say, is this high quality evidence where doing more research is not particularly likely to change the confidence that we have in the findings? Or is it moderate, where we might want to do a little bit more to increase our confidence? Or unfortunately, is it lower evidence where we really need to do more research and gather more evidence? So here we go. I'm going to walk through the standards, just say, a couple of sentences about each of them in the interest of time here. But the first standard is that we should conduct routine and systematic assessment of the psychosocial healthcare needs of youth and families. There was high evidence for this across a large number of studies, 149 studies. And the feeling that this is something that should certainly happen at the point of diagnosis, but also that should be repeated across the course of treatment. The second standard concerns monitoring neuropsychological deficits and functioning during and after treatment. And again, strong evidence for this across many areas of research. We also recommended in the third standard that we have annual screening of the psychosocial functioning of long-term survivors. Also quite strong evidence. The fourth standard was that families should have access to psychosocial support and interventions throughout the cancer trajectory and access to psychiatry as needed. So we know that some families are going to need more assistance than others, and we want to make sure that we're able to provide that. There's high evidence, strong evidence for that across a large number of studies. We also want to assess the risk of financial hardship and make referrals for extra support as needed. I have to say that at the time we did these reviews, the strength of the evidence was graded to be moderate, but actually we've had quite a bit of interest and studies in what we now call financial toxicity in terms of the impact of finances and economic constraints on families as they go through cancer treatment. The sixth standard pertains to the mental health of parents and caregivers. And again, interventions for them. These are particularly important topics from a family perspective. The seventh standard is to provide psychoeducation, information, and anticipatory guidance about the disease, the treatment, and long-term effects. We know how important it is that people have information and they have education and they are coached about what they might be likely to encounter as they go. Related to that actually is the 8th standard, which is to provide developmentally appropriate preparatory information about procedures and interventions that children receive as part of their treatment. And for intervention studies, this is high, strong evidence. It's less evidence actually for education. Again, sometimes there's not a lot of studies about something, but we know that they're very important. The 9th standard pertains to social interaction. And this really gets at the potential for social isolation that children and families have during treatment and paying attention to that. The 10th standard pertains to siblings. And of course, I could do a whole presentation just on siblings and the many issues and the importance and the importance for the whole family of really thinking about the siblings. The 11th standard pertains to school reentry. And our treatment centers, and perhaps yours too, differ some in terms of their of what families and children are coached to do when they have cancer treatment. But regardless of whether they're urged to stay out of school or to return to school or to have tutoring or additional help, it's really important to have those channels of communication open with the school. The 12th standard pertains to the assessment of adherence, monitoring, looking at the extent to which the treatment is being received as intended. Are kids taking their medication? Do we understand how to work with various families around successful administration of treatments that may be difficult for them? The 13th standard is the introduction of palliative care. And again, this is a big, big topic that we could have a whole presentation on. But thinking about developmentally appropriate end-of-life care as necessary and thinking about when and how to introduce that so that families are able to benefit as much as possible as they struggle with some of the course of treatment. The 14th standard pertains directly to providing bereavement care for those families whose child does die. And the 15th standard, which is a long one if you read the full standard, this is just an excerpt, but we really talk about the importance of respectful communication among providers and families, appropriate documentation of our work, and appropriate training of psychosocial providers. So it's really sort of a professionalism standard, and stressing how important it is that the psychosocial professionals that are working with children with families with cancer and their families are well prepared, supervised, and behaving in a professional manner as they do so. So we have been fortunate to get many endorsements of the standards from a range of professional organizations, primarily in the States, but we have a couple here that are international, and we'd like to see more international. But as you can see with a quick look at this, it's major organizations providing psychosocial care in psychology, psychiatry, social work, oncology, nursing, and also a variety of advocacy organizations that have endorsed the standards. So this is something that we want to see grow and develop. So I'm going to turn now more directly to issues of implementation. The green checks mean, yeah, we're doing pretty well with this. The yellow checks are things that we're still working on. Obviously, we've developed the standards and the guidelines. We've secured endorsements from organizations, as I just showed you on that slide. Jumping down to the other green check marks, we have key stakeholders participating. And this is both professionals, I mentioned psychology, social work, what we call child life specialists, nursing, and very, very importantly, families. And of course, as I mentioned, the standards were developed hand in hand with families, and particularly the Browns and their organization. We are anticipating the challenges. We know that you can't just say, hey, this is something that you've got to do, that this is more complicated. I'm going to talk a little bit now about the readiness. So that's why the words there are in green. What are the things that we haven't done so much yet? The things that we have to still think about? Well, going back up and then looking at the yellow check marks. I think we really need to be clear about what our desired outcomes are. How will we know when people have implemented the standards? How do we know if they're doing a good job at it? I think we need to really think that through. The standards are very general, and that was intentional. But now the other side of that is, I think we have to think about, okay, so what are the ways that you can meet these? There's many different ways. There's a lot of room for flexibility. But we also need to think about, what are the basic requirements? How will we know, again, if people are meeting the standards? And then the final three points on this list: to test the implementation. How are we doing? To evaluate it. Should we be doing things differently? Are there things that might support and facilitate the implementation of the standards? And then how can we best disseminate them? Not just in the United States, which is plenty of work to do there, but also internationally. And, what does this mean to you, for example, in Argentina? Where would you want to step in and begin to think about how to bring this, would you want to, and if you do want to, how would you bring this philosophy and these standards into your work settings? So I'm going to talk now a little bit about a study that we conducted across the United States. Again, the idea here being, if we're going to ask people to implement standards and to change their behavior, we need to know where they are at the beginning. And if someone says, how many psychosocial care providers do you have in a particular hospital, that information wasn't widely known. So we began a survey of interdisciplinary staff across, in total, there's about 200 centers across the United States that treat children with cancer. We got 72% to participate. So we thought that was pretty good, actually. You can always do better, but it was pretty good. Wanted to describe the readiness of the programs to implement the standards. Do you have enough staff? Could you do this? Could you provide the kind of care that we're asking people to provide? And what are they doing now? Some people might say, well, we're already doing a lot of that. Other people might say, we haven't done any of it and we don't know where to start. So we also wanted to look at the facilitators and the barriers to care. What stops you from doing it? What are the things that lead you to think it's important and to want to keep moving in that direction? So as I mentioned, we identified all the sites across the United States that treat kids with cancer. Our goal was to have 3 participants from each site: an oncologist, a psychosocial leader, and also an administrator. It turned out to be quite difficult to get the administrators, so we focused primarily on the oncologists and psychosocial leaders. We got names and addresses for people. That wasn't necessarily easy to do, but we found them, and we sent them a personalized link with the survey document. The survey was developed with our team and with the input of families and research experts, and it had 6 sections. We asked about the person filling out the form. We asked for some basic information about their program, the size and type of staff that they have, the type of care that they delivered, and the challenges and barriers that they experienced in doing so. The questionnaire involved a variety of Likert type scale, forced choice, and some open-ended questions. And the questions were variable based on the role and the discipline of the participant. So here we go. As I mentioned, we had about 72% of centers participate, and we got data from a large number of oncologists. 99 centers had an oncologist participate, and psychosocial leaders, 133 people, and you can see the breakdown there in terms of psychologists and social workers being the largest single respondents. But we kept getting a pretty good representation of some other folks as well. We only wanted one person per setting because we didn't want to bias the sample by having multiple people from the same place. So just to give you a feel for the type of data that we were able to collect. Is the current psychosocial staff in your center adequate for your needs? And what you can see here on the left, the responses of the oncologists from the orange, strongly disagree, to the darker orange, strongly agree, and the psychosocial leader on the right. And what you see there is what we saw over and over again on these questions, and that is that the oncologists and the psychosocial leaders tended to see things quite similarly. That was a little bit of a surprise to us because we thought that they might view things differently. So I think that's very positive finding in terms of thinking about how you would implement the standards. Those people find this slide interesting, both as a benchmark of psychosocial care, again, in the United States, but different centers, different people look at this and have found it helpful. What we see is that most programs, the top line there, almost 96% of centers have social workers in their program. And the median number is 2. They see a huge range there, right? From 0 to 24 on some of the big, really big centers. Going to the bottom line, child life specialists, again, you see over 90%, almost 93, over 93%. And again, a median of 2. So we feel comfortable in saying most centers in the United States are going to be relying on social workers and child life specialists. Beneath the, in the blue column, beneath the discipline, you see a ratio. And this is 1 to 40. That's one social worker for every 40 inpatients. It's not a great, I don't think it's a great ratio, but it is, you know, what it is. Child life specialist, 1 to 50. Now, when you get to psychology, neuropsychology, and psychiatry, you see that there are much less likely to have people of these disciplines in their programs, from 60% of psychologists to 19% of psychiatrists. And you also see, not surprisingly, that the ratios increase proportionately as well, to 1 to 350 for child psychiatrists in childhood cancer. That's fairly remarkable in a bad way. not what we want to see. I think I would be remiss not to also say that there were many other different types of psychosocial staff members on the psychosocial teams, and you can see the list there on the bottom. Also, speaking Spanish is very important in the United States, and what you can see there is that we're not doing too well in terms of providing our families with bilingual psychosocial providers, from 28% social workers to 7% or so psychiatrists. So we have some need for improvement there. Another question that we asked was the care that our pediatric patients and families receive is comprehensive and state-of-the-art. And what you see there again is this wide distribution. You know, some people saying that no, not at all, but 9% of both oncologists on the left and psychosocial leaders on the right, up to 12 or 15% that say we're doing a really good job. So we have a lot of variability here, and we'd like to understand more about what drives those differences. So how are we going to meet the standards? They are, as I mentioned, intentionally broad. We need to think very concretely about how each standard could be met. Is there a minimum that you would want to see for something like providing psychosocial support? We need to know the nature of care at the current time in order to improve it. That was what we were getting at with the study that I've just described. The barriers and the facilitators are necessary in order to design strategies that are going to overcome the barriers and that are going to be consistent with and build upon the facilitators. And we have to understand the full range of sites. As we've been doing some implementation work, I'm really struck by how much each center is unique in some ways. But certainly some of the things that we want to look at are the size of a center, whether or not it's affiliated with an academic program, whether or not it's in a state that may have more resources or have more, as we think of as progressive policies for support for families. I've mentioned stakeholders a couple of times, and I just want to highlight how important they are, how important it is that we all come together on behalf of the standards. So the psychosocial staff, of course, oncologists, nurses, other members of the healthcare team. Administrators are also important. You know, they often are making, they're in a position to make decisions about how resources are allocated. Patients and families, of course, are major partners and can also be very, very influential in terms of thinking about how care is delivered. We also have legislators. That's where we started with the standards, and that's kind of where we keep circling back to sort of say it's important that a society that thinks it's important to take care of kids with cancer and their families enacts that as part of its policies and part of its legislation. And in the United States, we have to worry quite a bit about payers or insurance companies or government programs. And I think although every country has different systems for how healthcare is paid for, I have yet to encounter a country where it's not an issue. You know, the forces and the representatives may be different, but the overarching concerns about how do we pay for this is always a consideration. So it's important to have those people be involved as well. And to wrap up, I just want to say this really is a global enterprise. We're very interested in expanding this work internationally and hearing from you about, you know, what does this look like for you? Where would you start? What are your needs for implementation? I've tried to highlight the similarities around the world. I know there can also be differences, and some countries, of course, have much fewer resources than others. And you know, children with cancer, they're clearly at greater risk. We want to develop medical and psychosocial services collaboratively, again, in models around the country, and internationally also highlight the need for training psychosocial providers so that we have a workforce of people who know how to do this work and know how to do this work well. This concludes the oral part of the presentation. I wish to thank you very much for your attention, and I look forward to the discussion that we will begin at this point. Thank you very much again. I appreciate your attention.
Me imagino que deben tener muchas preguntas. Excelente el tema que trajo Ann sobre los estándares, que es un tema que a todos nos preocupa. Le preguntamos a Ann acerca de dentro de los estándares. En el quinto estándar ella hace referencia al riesgo económico que sufren las familias y utiliza un término que se llama toxicidad financiera. Entonces le queríamos preguntar un poco si podía ampliar este concepto y su relación con la adherencia a tratamiento, ya que es un tema que para nosotros en Latinoamérica tiene un alto impacto.
Okay. And if you can start.
Okay, sure. Thank you. I'm glad to try to answer that question. I think what we're talking about here is poverty, and poverty is a universal problem. And I do want to be clear that, you know, my experience is from the United States, and I understand that things are not the same, that it's a different system in Argentina.
Quiero ser clara que lo que estamos hablando en esta oportunidad es de pobreza, y en ese sentido quiero ser muy clara que, por supuesto, no es lo mismo en Estados Unidos que en Argentina.
I think, though, that poverty and economic problems are a huge universal concern for children and families, children with cancer and their families, and something that we all have to think about, you know, how to address this. And sometimes it's very overwhelming, right, to know how to address poverty, because it's it pervades every aspect of people's lives. Sometimes there are things that can be done.
En este sentido, quiero ser clara que estamos hablando de pobreza. La pobreza es una problemática universal que atañe a todas las familias. Y could you repeat the last part? And I got kind of lost. Que en la medida que hay pobreza se depriva y se pasa por encima de otros aspectos.
Yeah, I was, going to say that I think in every country and every culture, we have to think about how to address this. And at the level of patients and families, for example, in many of our hospitals, we have somebody who provides financial counseling. And
en este sentido, hay que pensar en responder a esta problemática en cada país y con cada cultura. Y es por esto que nosotros, por ejemplo, en nuestros hospitales tenemos una persona que responde a problemáticas financieras, económicas.
And in this way, helping people, fill out paperwork for different benefits and that kind of thing. And also, thinking about ways that things like helping people get access to food if they don't have access to food. We talk about food deserts in the United States, even in urban areas where people are not getting enough food and are stressed by having to look for their food.
En este sentido, estas personas lo que hacen es ayudar muchas veces con completar formularios administrativos para poder recibir algún tipo de beneficios, incluso el hecho de poder acceder a ayudas económicas para la comida. En Estados Unidos hablamos algunas veces de desiertos de alimentación, incluso en áreas urbanas hay mucha gente que tiene dificultades para acceder a la comida.
I think the other thing is to consider policies and, at a national level, if a parent misses work because their child has an appointment in the oncology center, are they at risk for losing their job? Are there protections for their job if they need to take some time off? And I think, these can become parts of laws or policies or things at a broader level that support families. And again, I apologize for not knowing more about how that might operate in Argentina.
En este sentido, ella dice que muchas veces esto tiene que ver con políticas públicas de salud y con cuestiones mucho más amplias, como por ejemplo el hecho de que un padre pueda llegar a perder el trabajo o tener alguna dificultad laboral por tener que asistir a una consulta con su hijo que está enfermo, y qué pasa con ese padre que tiene la dificultad a la hora de faltar a su trabajo, si tiene algún tipo de ayuda o aval o espacio de posibilidad de no hacerlo y poder cumplir con la consulta de su hijo, que esto es una cuestión muchísimo más amplia que tiene que ver con políticas públicas de salud, y ella pide disculpas particularmente por no saber las cuestiones específicas de Argentina, también antes le habíamos comentado sobre esto y ella había dicho que muchas veces la cuestión de adherencia al tratamiento se relacionaba con esto, con el hecho de no asistir a una consulta médica por necesitar trabajar y por ahí no poder cumplir con el cumplimiento de esa consulta con su hijo. Okay, and we have another question. It says, in the survey to oncologists and psychosocial leaders, who were the psychosocial leaders, the heads of the service or the team members? I will say this question in Spanish, maybe I can repeat it afterwards. Dice que en el cuestionario sobre los oncólogos y los líderes psicosociales, ¿quiénes eran los líderes psicosociales? ¿Eran los líderes de la cabeza de los servicios, digamos, o los miembros del equipo? Would you like me to repeat the question?
No,
Okay.
I think I got it. You know, it's a good question. Because we got information from, you know, 140 something centers, we saw a wide range in how the psychosocial teams were organized. So in some of the bigger hospitals, you might have a whole team, often headed by a psychologist, sometimes by a social worker.
I want to translate, not to lose the idea, sorry.
Okay.
Dice que como tuvieron una gran cantidad de respuestas, vieron una diferencia muy grande en los distintos equipos que analizaron, tuvieron más de 156 respuestas, y lo que vieron es que en los hospitales más grandes, you were saying, Anna, about the big hospital, sorry?
Yeah, and in other places, however, sometimes we had difficulty even finding one person, you know, so there was a big variation, and we had several hospitals where there might be one social worker who is providing care to, you know, say cancer, hematology, transplant, diabetes, you know, not even devoted just to cancer.
Okay.
So big variability there.
Dice que hubo una gran variabilidad en relación a quién era el líder, y que muchas veces, incluso en algunos hospitales muy grandes, había una sola trabajadora social que se hacía cargo no solo de pacientes oncológicos, sino de una amplia cantidad de enfermedades, entonces que no había incluso un líder que estuviese solamente especializado o trabajando únicamente con este tipo de pacientes, sino que había mayor variedad, y que esto fue muy cambiante en relación de quiénes eran los líderes en las distintas instituciones analizadas. The other question that we have is, what is a child life specialist? Esto sería en español, que es un especialista en vida infantil. That we don't know if we have that kind of figure here in Argentina, que no sabemos si existe específicamente esa profesional de la salud acá en la Argentina.
Yes, child life specialists are, they usually have advanced training in working directly with children in medical settings. So they might be providing play-based approaches, interventions. They may be providing support. Say when a child has to go through procedures, they might be preparing a child for, say, an amputation or something like that. So they're trained in how to work with children, very specifically around how to talk.
Estos especialistas reciben un entrenamiento especializado en cómo manejarse con chicos, especialmente en cuestiones de cómo manejarlos frente a un procedimiento, muchas veces una amputación, sobre cómo jugar con ellos previo a la realización de un procedimiento. Okay. Do you want to expand a little bit more, or we are just with that? It's okay. 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 Now we have sí, Teresa.
No.
Okay. People for the person from the audience that says that it was an excellent presentation, and that in Argentina a study was carried out on whether the different hospitals in the country complied with the psychosocial recommendations of the International Society of Pediatric Oncology, and the results indicated partial compliance. Do you think the standards should be specified since they are so general? I will repeat this in Spanish and let you think a little bit. I will repeat it for you if you want it afterwards. So, en español dijeron que fue una excelente presentación y que en Argentina se hizo un estudio acerca si en los diferentes hospitales del país se cumplía con las recomendaciones psicosociales de la Sociedad Internacional de Oncología Pediátrica y que los resultados indicaron un cumplimiento parcial. Y lo que le preguntan a Anne es si cree que debería especificarse los estándares ya que estos son tan generales.
So, what I would like to see, first of all, that's very interesting to hear about your study. That's, fascinating. What I would like to see is people become aware of the standards. And then... Lo
primero que dice Anne es que, que le parece muy interesante el estudio que llevaron a cabo y que lo primero que es interesante pensar es que la gente empiece a tener noción, conocimiento de los estándares.
And there's 15 standards, that's a lot. So we're actually interested in identifying which are the most important to people. And I think that's an important question to ask.
Okay, hay 15 estándares, eso es un montón, y nosotros estamos muy interesados en entender cuáles son los más importantes para la gente, y esa es una tarea sumamente fundamental.
Yeah, so I think if any given hospital or treatment center can identify 2, 3, maybe even 5 standards that they think are most important, then they can focus on those. Because I think to try to do all 15 at once is very difficult, but rather to make progress on a couple of them. That's how we're thinking about them in the States.
Dice que en los Estados Unidos están pensando mayormente en seleccionar 2, 3 o incluso 5 estándares que sean los más importantes para la gente y que muchas veces es más importante focalizar en algunos pocos, ya sea 2, 3 o 5, para poder avanzar sobre eso, porque 15 son muchos y en Estados Unidos lo están pensando de esa manera. Okay. I will see.
Yo tengo una pregunta en relación a eso. Que la verdad que son excelentes los estándares y en esta encuesta que decía alguna colega, en la que participamos de todos, digamos, de la Sociedad Argentina de Hemato-Oncología Pediátrica, trabajamos el área de psicología, de psicosocial, con esta encuesta, y nos pasó que la dirigimos a los jefes de servicio y pasó lo mismo que dijo Anne. Quizás el jefe de servicio no atendía a esos pacientes oncológicos porque no hay una especificidad es muy difícil que haya un trabajador social específico para oncología, o sea que hay una similitud.
Teresa was saying that they participated in this survey that they mentioned in this country about the standards and that they kind of focused this survey on the team leaders in the chief of the oncology group, and sometimes they had the same results in the sense that these professionals were not treating only an oncology patient, but a lot of different diseases, and they didn't have this kind of social worker that focused only in oncology, but also in another kind of hematological diseases or other kind of problematics.
Y ellos incluyeron a los administradores que es algo que nosotros no pensamos, y le quería preguntar, bueno, ¿por qué pensaron en incluir dentro de todos los profesionales a los administradores?
Teresa was saying that a difference in the two studies or investigations were that you included the administrators or managerial, I don't know, roles in the study, and she wanted to know how did you decided to include these professionals because they weren't like prioritizing that kind of roles, and that's a great difference and something interesting to understand more.
Yeah, well, we wanted an oncologist and a psychosocial person because we wanted to be able to look at, how those two groups. We wanted the administrator because, again, in the States, I wanted to know how is this care funded? How is it paid for? And but I'll tell you the truth here. It was very difficult to find the administrators, and very difficult to get them to agree to do the study. And honestly, I wouldn't do it again. It just, it was a lot of work for not a lot of data. It's important data, but they were hard to find, and they often didn't really, provide us with, with much information.
Dice Anne que, por un lado, en primer lugar, les interesaba tener la perspectiva tanto del oncólogo como la perspectiva psicosocial, pero también en Estados Unidos, por las características, les interesaba saber de los administradores, porque querían saber cómo era el financiamiento, el reembolso, de dónde salía la plata, pero para poder llevar a cabo los tratamientos, pero que muchas veces se encontraban que era muy difícil que los administradores den el consentimiento para participar de la investigación, que fue muy difícil encontrarlos, que si ellos tuviesen que volver a hacer la investigación probablemente no los incluirían porque fue un trabajo muy exhaustivo para conseguirlos y la data que obtuvieron a partir de esto no fue significativa. Así que dice que es un rol muy importante, pero que fue realmente muy difícil y que dijo como, les voy a decir la verdad acá, no los volvería a incluir. Okay.
Muchas gracias. Por el tema del tiempo, tenemos que cerrar. Thank you, Anne.
Thank you.
Teresa was saying that due to time and other presentations, we have to close here, but she wants to thank you for being a part of these conferences and want to keep in touch afterwards for other investigations and kind of continue working together.
Yes, thank you for inviting me and for making me so comfortable here in this virtual space. I really appreciate it. And I also want to just thank you, Sophia, for translating. I know it's a lot of work.
Okay,
you can't rest for a minute when you're doing translation. So I appreciate that.
Dice Anne que está muy agradecida de participar y que la hicieron sentir muy cómoda en este espacio virtual y que agradece muchísimo la participación.
Thank you.
Bye-bye.